like to begin with the introduction of our first presenter this morning, and it is an honor and a pleasure to welcome our first speaker this morning, the Honorable Deborah Senn from the great state of Washington. Ms. Senn completed her undergraduate education in history and went on to complete a master's in political science at the University of Illinois. That was at the Champaign-Urbana campus, and subsequently she earned a JD degree at Loyola University School of Law. Ms. Senn was the first woman ever elected to the position of Insurance Commissioner in the state of Washington. She completed 2 terms in this office, serving from 1993 through 2001. She is widely recognized as a strong consumer advocate. While serving as the Insurance Commissioner for the state of Washington, she was acknowledged as the best insurance commissioner in the United States. Ms. Senn is credited for fighting and creating access to insurance for alternative and complementary care professions, including chiropractic, naturopathy, massage, and acupuncture. Ms. Senn brings this background to her current work as an attorney, an expert on insurance matters, and she has been active in the Zelke law firm in the greater Seattle area and representing chiropractors before the Washington Department of Health. Deborah is also an international consultant on insurance regulation, having worked in insurance-related matters in Vietnam, Cambodia, Serbia, Algeria, Kosovo, Bosnia, Paraguay, Armenia, and Haiti. And if she can sort out healthcare in those areas, the States is nothing to it. On a personal level, I have spent the great majority of my career on the West Coast, and throughout that time I've had very close relationships with the Washington State Chiropractic Association, and have enjoyed having a number of their members on the Board of Regents of Life Chiropractic College West when I was president. And I had many opportunities to be in Washington, many opportunities to appear before the state legislature, before different commissions on behalf of the association. And the one person that every representative from the Washington State Association always talked about with great pride, great respect, great honor, and great dignity was our speaker, Deborah Senn. Ms. Senn is not one of those individuals who is elected to a position and gains support along the way from various circles as one needs to be elected, and then forgot about how she got where she got. She began concerned about access and availability of services from non-traditional providers, and she maintained that orientation throughout her entire 2 terms as insurance commissioner. And she went on to pay a very heavy price for her association with us and with our colleagues in the CAM community, was attacked relentlessly by her opponents in the state from the traditional side of healthcare and the traditional side of the insurance industry, and stood her ground and held her position on behalf of the public, on behalf of providers of all stripes, and she served the people of Washington, the people of our professions well. And because of those actions, those early days, Washington helped set the stage for what really has come to pass or is coming to pass across the nation. And I think in the fullness of time, we will realize that the efforts of Ms. Senn in the state of Washington became a template for what will happen and what we will see develop across the country as healthcare reform unfolds. At this time, ladies and gentlemen, would you welcome to the platform from Washington, the great state of Washington, the Honorable Deborah Senn. Deborah?
Thank you, Gary. That was fantastic. So
Just take you forward. Okay.
Oh, here I am. Thank you, Dr. Klum. What a great introduction. What a great honor to say such nice things about me. Good morning. I'm really pleased to be here. I'm honored to be the morning keynote, although it's 5:30 in the morning my time, West Coast time, and I'm sure the room will be a little more full, so you guys are the hardy ones to come out early. I think I'll start with a little healthcare story to try to warm things up a little bit. As Jerry mentioned, I was the insurance commissioner of the state of Washington from 1993 to 2001. You know, there's nothing better for a policymaker or an elected official to know the issues than to experience them. So I used to tell this story when I was commissioner. In 1999, I actually was skiing near Mount Rainier, in our beautiful state of Washington, and I was on a kind of a blue medium slope, and all of a sudden I see this big blur coming at me, and it was a first-time snowboarder who was out of control. I mean, he looked like a bowling ball, and I was the pin. And he hit me so hard that I flipped up in the air backwards. I actually heard my back crack. I thought he had broken my back. I was, you know, in the air. I was thinking about it. And I hit the ground, and I could move my legs, and I tried to get up, but I couldn't pick my arm up off the slope, and ultimately it turned out that I had broken my arm. Now, the good thing about this first-time snowboarder, unlike most hot dog snowboarders, he actually stopped and waited with me for the ski patrol. In fact, he offered me a cigarette like we were in a World War II movie. Anyway, so the ski patrol came and they picked me up and they took me down, and it was, you know, never having really had any health problems. I was never on a gurney. They pushed me into the first aid station, and I had my ski mask on, and the doctors pulled it off, and the doctor looked at me and went, Commissioner Senn, I have some healthcare questions for you. And so he said, I heard you speak on alternative providers, and I know what you've been doing, even though this was an MD, I think, I don't even remember, in the ER hut on the ski slope. Anyway, they sent me along I went back to Seattle and went to the hospital near my home, and I got my bill, of course, and they charged me, and I know a lot more about this since this happened. They charged me for an out-of-network hospital visit. You know, and I called the insurance company. It was an emergency, and actually I've done a great deal of work on ER issues, which is not on the floor today, but because, you know, by nature of an emergency, who can go to an in-network provider? You know, and so I had to argue with them, and then after that, did work on that issue to make sure that emergencies were treated as in-network. And ultimately, they adjusted my bill, but my advice from then on is that you always have to have your provider list with you at all times, you know, no matter where you are, in case you have an emergency, so you can go to an in-network provider. Anyway, that was my first experience with the healthcare system. And actually, to tell you the truth, the way that I knew a half a dozen issues was through paying off my own bill and experiencing the insurers trying to shut me down or not pay. Of course, as soon as they found out who I was, that fixed the problem actually almost immediately. I actually used to tell in speeches in the state of Washington, just use my name, say you're a friend of mine, and it used to get people far along with the insurance companies. All right, so that was supposed to be kind of a wake-up story. So I'm here to talk a little bit about the implementation of, and we have till 9:30, is that right, Jerry? So I'm here to talk about the implementation of Section 2706, which is the anti-discrimination provision, which in the Affordable Care Act, which is going to affect you and your patients probably as much as any provision under the Act. Now, Jerry did tell me that I had doctors in the audience, and so those are the issues that I really want to address. And one of the reasons that everybody likes to take me out of mothballs to talk about some healthcare issues is because in the state of Washington, we implemented a law in actually 1997 which allowed access to complementary and alternative providers. And we had many of the experiences that the federal government is having with the implementation of the Affordable Care Act. We got sued. We went all the way up to the Ninth Circuit, which is the one court below the Supreme Court. You know, we won. And so I really have kind of been through the mill on how to implement this kind of law. And so that's what I'm here to talk about today. And so what I'll do with my slides is I'll kind of go through how the law works. And because I have a shorter version of this, but because you know, you're doctors and you're from different states, I presume, I want to talk a little bit about what to expect. As Jerry mentioned, the WSCA, which is the Washington State Chiropractic Association, is a very active one in our state. We were always great friends, and many supporters of mine were from the chiropractic profession. And in fact, the current director of that association is a woman named Lori Belinsky, who was on my staff, and she left my staff when I left office to be the director of the Washington State Chiropractic Association. But what's interesting is she by background is a licensed massage therapist, and I hired her to be my provider liaison when I was insurance commissioner. And so that's kind of one thing to think about. Most insurance commissioners do not think they have jurisdiction or don't necessarily have liaisons with the provider community. In fact, when I became insurance commissioner, the staff said, "You're not supposed to help doctors." I said, "Well, why not? They're part of the healthcare system. No, you can only, you know, help consumers and regulate insurance companies." I said, "No, that's not the case." And actually now I've found, I'm doing some work in California. In California, if you are, I don't know if we have anybody here other than Jerry from California, if you are a healthcare provider, you actually can complain to the Department of Insurance if you're having difficulty being reimbursed by an insurer or getting on a panel or licensing issues. And so actually I've looked at their process, and that's really developed in the last decade. And that's something that the insurance commissioners really need to do and to think about. Finally, let me just say that I was a commissioner in the 90s along with Kathleen Sebelius from Kansas, who is now HHS secretary, and Steve Larson, who was the commissioner from Maryland, who's now the head of CCIIO, which is the implementation arm of the ACA, the Affordable Care Act, with Jay Angoff, who was the commissioner from Missouri, who had Steve Larson's job prior to Steve, with Joel Araria, who was the former commissioner from Oregon and Pennsylvania, who was put in charge of implementation of exchanges, although I understand he's left, and Sally McCarty, who's working on rates at the HHS, who was the commissioner from Indiana. So what's kind of interesting is that insurance commissioners were kind of an unseen remote group until Kathleen Sebelius was appointed secretary of HHS. And now they're really in the forefront of implementing the Affordable Care Act, and a lot of issues are being sent down to the Insurance Commissioner Association, which is not just an association, the National Association of Insurance Commissioners. The NAIC, you know, basically is a kind of an arm of the HHS in terms of implementation for the states. So that's just a good organization to know about and to be aware of how those dynamics are working. All right, so let me begin. I always like to find my cartoons on insurance. I don't think it's going to be extinct too soon, but I always like that. Didn't get much of a laugh. Now, I want to start with the issue of consumer demand. The one thing that I think that is more important than any is the fact that consumers want access to their chiropractor or to their naturopath or their acupuncturist, or for Nancy's purposes, to their homeopathic physician, because you know, consumers have a pretty good idea of what they're looking for oftentimes in their health care. And so this is an issue that is really driven by the public, and that's really good. And I know that I used to have a kind of a tumultuous relationship with the head of Blue Cross in Washington State. Nonetheless, and she, every year she was trying to kill access, but did she have her own chiropractor? You bet she did. And it was both sides of the aisle. I was in D.C. a few weeks ago, ran into Senator Hatch from Utah, who's an opponent of the Affordable Care Act, but he is a proponent of access to choice of providers. And so this is an issue that crosses both sides of the aisle, and that's enormously important. All right, so Dr. David Eisenberg of Harvard University, who many of you may have heard of, did the early study, I think it was like 1990 or 1989, which said that, and this was at that time, 40% of people go to complementary and alternative providers, and 80% don't tell their MD about it. I think he redid that study, and I didn't put the data in, but I think it's now up to 60%. And I guess people now tell their MDs about it because the MDs are more accepting of it. And I know in the state of Washington, if you have cancer, you've got an array of alternative providers on your health panel in addition to your oncologist. Oh, there you go. I think that's probably the latest Eisenberg study. So it was 67.6% used at least one CAM therapy in their lifetime, right? So that's an important statistic. All right, so let me jump in and talk a little bit about the law. So this is section 2706. By the way, at the end of my talk, I've decided it's the anti-discrimination provision, but I've decided that here and now, we've got to come up with an acronym for it, and I solicit your ideas so that we can start talking about it. Actually, on the plane last night, I thought we could call it the CLIP provision, choice of licensed insured provider, something like CLIP. So, and if anybody has any ideas, you know, and then we could start marketing it as an acronym, and then people would know what it was about. All right, let me show what the law says. It's pretty simple. I gave you all the words, though. A group health plan offering group or individual health insurance shall not discriminate, that's the key word, with respect to participation on the plan, under the plan, or coverage against any healthcare provider who is acting within the scope of that provider's license or certification under applicable state law. Now, there's two important elements here. Number one, you can't discriminate. Number two, you have to act within the scope of practice. Now, I do work with the naturopathic physicians. I was just asked the question, what about a state where naturopathic physicians aren't licensed, and that's an issue? I assume that chiropractic doctors are licensed in just about every state. By the way, hats off to the chiropractic profession for their political sophistication and experience in that process, and that is why you are licensed in every state. Okay, so that's the first half of the law. The second half, no, that's the same thing. Let me see if I got the next one. This section shall not require that a plan contract with any healthcare provider willing to abide by the terms and conditions for participation, and nothing in this section shall be construed as preventing a group health plan or a health insurer issuer or the secretary from establishing varying reimbursement rates based on quality or performance measures. So what this is not is an every willing provider law. The one place they have an every willing provider law that I'm aware of is the state of Kentucky, which means that every provider gets on the panel. And interesting, you know, the U.S. Supreme Court upheld that law with Anton Scalia, who you would think to be an opponent of healthcare. Actually, we will see in the next couple of months where Anton Scalia is, but I can guess. But Anton Scalia voting for it so that people have access to any kind of provider that they feel will suit their healthcare needs. All right, so that's what the new law says. Now, I'm going to flip over to the state of Washington, and I'm going to show you what that law said, because it's almost identical. Every health plan issued for delivery by January 1st, 1996, shall permit every category of healthcare provider to provide health services or care for conditions included in the basic health plan to the extent that it's within the healthcare provider's permitted scope of practice. Same idea. The one thing that the Washington law has, which will be interesting in looking at the Affordable Care Act, is it gives you a measuring stick. It says for healthcare that you find in the basic health plan in the state of Washington for low-income people, we have something called the basic health plan, and the benefits in that plan are a good measuring stick. Now, I don't think this is going to be a problem in the federal law, and in fact, I know we've got a speaker after I'm on this morning talking about the exchanges and the essential benefits package, and so that's an issue that we have to address. But it's essentially the same as the federal law. And then it just says the providers agree to abide by standards related to utilization review, administrative procedures, and cost-effective and clinically efficacious health services. You know, it's interesting about that last provision because we've had some really good studies in the state of Washington about the efficacy and the cost-effectiveness of alternative, complementary and alternative providers. I'll just use the term CAM providers. In a sense, we've fulfilled the mission of that law. Okay, now I want to talk about the implementation because in 1997 or 96, when the law was passed in the state of Washington, it was my job as the insurance commissioner to implement it. And so initially, the insurers had some misconceptions. They said, oh, this is going to be too expensive. And so I want to talk about what we did. John Weeks is in the room, and he's going to be talking, I think, to you tomorrow. And I actually retained John Weeks and one of his colleagues to create a clinician working group in the state of Washington, where we had insurers and CAM providers on this work group to implement this law. So they were talking to each other because a lot of the insurers had no experience about pricing or how to implement CAM service or CAM providers for the benefit services in their package. So I have a typo here. That's actually Blue Shield. So we're sitting in a conference room. I always like to tell this story because I think it's the key to understanding the provision. And the general counsel for Blue Shield in the state of Washington was sitting there, and he said, well, let's take the example of somebody has a back problem. And you know, they're going to go to a chiropractor, and I'm going to have to pay for that. And then they're going to go to an orthopedic surgeon, and I'm going to pay for that. And so I have two charges I'm going to pay for. And so actually, one of the providers at the table said, no, I don't think you understand. If they go to the chiropractor, or she might have said massage therapist, but if they go to the chiropractor and they fix the back problem, then they're not going to go to the orthopedic surgeon, and you're going to save about $10,000. And I mean, it was at that base level that the insurers did not understand, and that was the beginning of understanding. And in fact, that plan, which is now the biggest in the state of Washington, was the most open in terms of implementation. So, as I said, they were misinformed. I had a CEO say, I don't even know how to credential an acupuncturist or a chiropractor. And so it was really important for the two parties to talk to each other. Okay, so here's the parade of challenges that I had. First of all, the entire law was challenged in court. Now, just to kind of a nuts and bolts observation, because this is really important, because when I went to HHS to talk to them about the new provision, they said, well, do we need to write rules? Is it pretty self-executing? And that was a really interesting question, because I thought our law was pretty clear and pretty self-executing. So I didn't plan to write rules initially. I actually put out a bulletin, which is something, it's a tool insurance commissioners have, which says, look, this is what the law says, now insurance companies go do it. And they sued me over the bulletin. And so we went to court, they sued the law, they said it was a violation of ERISA. It was not, but that judge on the federal district court level didn't understand ERISA because no one understands ERISA. And so he upheld their arguments, to my incredible shock. It went up to the Ninth Circuit Court of Appeals, and in 5 minutes, that's an overextended court, they reversed it and they upheld the law. So we've got some really good federal case law on access to complementary and alternative providers out of the Ninth Circuit on the West Coast. So they sued me. What else did they do? Well, they decided to exclude whole groups of licensed providers. They put limitations on the number of visits. Well, you experience that now. You cannot stop it, but you cannot put so much limitation on, that it's really, that it's pointless to try to go to a CAM provider or a chiropractic doctor. They put caps on the dollar amount of coverage, which they do now, but they continue to do it. And then, of course, they only allowed, for example, group health, a big HMO in our state, only allowed for 3 naturopathic physicians in their plan. It's interesting because most of the plans in Washington had much more experience with chiropractors than they did with naturopaths or acupuncturists, and that's to your credit and to your association's credit for really educating the insurers way before I came on the scene about what you do. I guess I have to. I didn't know I had this little cool fly-in business in my thing. I have to take it out. They limited the time for the service, a 1-hour appointment. I would go to my chiropractor and be treated for an hour, and they would pay me for 30 minutes and say that's all we're going to pay for. They tried to narrow the scope of practice. They said that naturopathic physicians could only treat for 3 things when they have a full scope of practice. Acupuncturists were limited to MDs. Only MDs could put the needles in. And as I said, naturopathic physicians can only do 3 services. They also offered extensions to small groups for compliance. It's like, the insurers had taken over the implementation of the law. Misrepresentation over the telephone to subscribers. Even though there was a lawsuit, the law was still in effect. But a subscriber would call up and say, I want to go to my chiropractor. Well, there's a lawsuit. And so people would hang up and not go to their chiropractor. They applied it to in-network coverage only, very big problem. And they made a PCP referral requirement for CAM and no other type of provider. So those were the kind of the direct consumer impacts. All right, so let me tell you what they did with the providers. One of the things I did as insurance commissioner, and once again, your insurance department should have the authority to do this, is that we've discovered early on in my term that we had authority over provider-insurer contracts. We could approve the language and a lot of the provisions. And so what went into that contract was extraordinarily important for the chiropractic doctors. So we found big problems in the contracts. They would use different contracts with CAM providers than they would use with the MD Association. And by the way, the MDs had plenty of problems. I used to referee King County or Washington State Blue Shield and the biggest doctor group in all of Washington. I used to be the referee on that provider contract because they were so much at loggerheads. But what they did is, in our state, they used subcontractors to contract with the chiropractors, and they used an illegal contract, as far as I'm concerned. And I discovered that after I left office. and raised it. I was through my law firm, and they actually stopped using that contract. So that meant that they failed to comply with state contract filing requirements, meaning there were certain things they had to do under the law when they contracted with a chiropractor. They didn't notify doctors of chiropractic of duties and responsibilities under the contract. They did not disclose in these subcontracts termination or audit procedures. As I said, I work with the Zilke Law Firm, and I represent a lot of chiropractors. And you know, I can't tell you how many times we've got to get a call, and it's like, wait a minute, Blue Cross is here to audit us, and they gave us no notice, yeah. Right? And in the contract, you have to have notice if they're going to come in and audit your patient files and your records. And many a time we said, well, tell them you know you're waiting for your attorney, and don't show them a thing. Failure to have an adequate grievance procedure constituting a fair review. A grievance procedure for a provider constituting a fair review is the law in the state of Washington. Yet they would issue a contract to a chiropractic doctor, you know, with no grievance procedure at all. And as I said, so we saw some unfair audit practices, no notice, confusion over audit deadlines. We've seen retaliation. We've seen unfounded allegations of fraud in order to extend their auditing authority, and insufficient notice of what the actual charting requirements are. Finally, some illegal termination practices, no provider manuals for CAM providers, untimely payments, and burdensome documentation. So these are the things that we experience in the state of Washington, and so these are the things that I'm going to talk to HHS about in terms of you know, what to look for when they implement the anti-discrimination provision. So, as I said, there's a Kruger decision in the state of Washington which sets standards for a fair grievance process for providers. You have to have, if you have a dispute, you get 30 days. Are disputes covered? Is the grievance procedure unfairly helpful to the carrier or the insurer? You know, is there a requirement for arbitration? This is just some of the, I threw in here just some of the standards that the courts lay down for providers in our state. It's maybe a little too much detail. And then once again, this is just, you know, in our state, billing disputes must be resolved within 60 days. You can't drag it out. You know, the provider has access to non-binding mediation. And so anyway, those are just some of the issues. Okay, so the bad news is that they sued us. The good news is that we won. The bad news is there was non-compliance. The good news was that there was a victory in the Ninth Circuit, and this is a really important issue. The Ninth Circuit said in its decision, because the very last argument the insurers made is that access to CAM providers is a mandate, and therefore it didn't meet the requirements of a mandate. And the Ninth Circuit said, which I think is a really dangerous argument, because that means that they can begin to say, well, if it's a mandate, then it's a service, because you know a mandate is like phenylketonuria, you know, I know that we had elements of breast cancer reconstruction that weren't covered that were mandated. You know, so if they can argue that it's a service, then they can argue for added cost. And so it's really important that the Ninth Circuit said, no, it's not a mandate. You know, you don't call going to your physician a mandate. And so I think that's a really, really important issue. Now, one of the things that happened in our state is there were like 4 or 5 very successful class actions against the insurers for failure to comply with the every category provider law, the anti-discrimination law, and every one of them was settled. And then the providers turned around and tried to do the same thing again. And then, of course, the Office of the Insurance Commissioner successfully enforced the law. So it's been a successful law in our state, you know, but you can see that there were many, many bumps in the road, and those are some of the things that we've overcome. So the good news also, actually the best news, is that Regents, which is that Blue Shield plan, I forgot their name, they're now called Regents, did a study. And in fact, this study, I think they kind of tried to hide it. And then this study came out in one of the class action lawsuits in discovery. And here's what it said. There is significant potential to control costs with alternative health care. This is out of the mouths of the insurers. There is mounting evidence that practitioners of alternative therapies can be highly cost-effective relative to conventional providers at treating increasingly pervasive chronic and stress-related conditions, and it saves money. Savings of 30% and more have been found in recent European outcome studies such as heart disease, chronic pain, respiratory illness, diabetes, which are a major cost driver in healthcare and for which conventional medicine has less, I don't know why, that's a typo, I scanned it, cost-effective treatments. So this is a really important thing that the carriers have done a study that says what you do as doctors of chiropractic is not only efficacious, it's cost-effective, and they finally get it. Now, we've got to transfer that knowledge to the federal level. Some more recent studies, once again, done in Washington State. CAM users average $1,420 less in annual healthcare expenditures than non-users in patients with the heaviest disease burden. And I've got all these footnoted if you want any sources. Corporate health management programs associated with prevention and wellness showed a 26% reduction in healthcare costs and a significant return for every dollar invested. This is something you've known for years, but it's important for corporate health management programs to begin to understand that. Median per visit expenditures for CAM care were $39 as opposed to $74 for conventional outpatient care in Washington. Total expenditures per enrollee were $2,500, only 2.9% spent on CAM. A systematic review of cost-benefit analysis of CAM compared to conventional care revealed 42% of the published studies showed cost savings. So every study that's been done in our state show cost savings. All right, so that's kind of the background and our success. So what is the way forward? First of all, where is the process? So the anti-discrimination provision is slated to go into effect in 2014. So I actually have visited with HHS, and they haven't even begun really to think about writing the rules simply as a matter of timing, plus the fact that, I'm sure someone's going to ask, and I'll jump to the question of, what is going to happen and what if the court, the U.S. Supreme Court repeals a portion of the law or the whole law. And so everything at HHS is pretty much at a standstill because of that, and because it's an election year. So the question is, should there be rules? And I've recommended that they do write rules, and they're actually interested in seeing what we propose. Who will write the rules for this law? Well, what they've told me is HHS. Now this is really interesting because I had a discussion with one of your speakers, with Matt, about the Department of Labor. If the Department of Labor is supposed to write rules or have oversight, then it means that it applies to self-insured plans, which is a little murky when it comes to what parts of the ACA apply to self-insured plans and what parts don't. If there are any tax consequences, the Department of Treasury. Finally, the really big question, I think, is, as you know, or maybe you don't, because it's a little obscure, the ACA was supposed to create something called the Essential Benefits Package, which is kind of a standard package of benefits. That authority has been kicked down to the states from HHS. And so right now, every state can write their own essential benefits package, which is, I believe, and Matt will correct me if I'm wrong, the package of benefits which will be offered in the exchange. Now, the question is, and as I understand it, if they pick an essential benefits package that doesn't have, for example, mandates in it, then the state, according to the law or the regulation, the law maybe, has to make sure that the mandates are covered. In our state of Washington, a month ago, the governor signed our exchange bill, and they picked one of our plans as the representation of what's going to be in the essential benefits package. So the question is, once again, access to chiropractic is not a benefit. It's not a service. It's about, if your back pain is covered by the essential benefits package, who is it that you go to? Do you go to an orthopedic surgeon or do you go to a chiropractor? And so I think we have to really make sure on a state-by-state basis to clarify that in both the essential benefits package and the exchange. And so these are the things that I'm thinking about in terms of how to implement the anti-discrimination provision. So finally, I thought I would leave, it says, this is your surgeon, and over here is Mr. Spudgeon from accounting, who will be in charge of your operation. So we're trying to get away from this issue, and so these are the issues that are very important. Once again, we have had some good successes in our state with regard to healthcare. Now we want to pass that along to the whole country. You guys do such a great job and have such a great role in teaching the policymakers and through the mouths of your patients. One thing I loved about doing health policy in Washington is that there were thousands of chiropractic patients in our state, and they got it. And the doctors were very proactive and talked to their patients. And so, I started with the idea that it's the public that wants choice of doctors and access to their chiropractor or their CAM provider. And it's the public that really is going to drive this process. And so that's why this is such an important issue. And your increased participation, I kind of use this because, and I talked before providers groups, when you went to school to become a doctor, you didn't realize that you'd have to be an accountant and a lawyer, and a billing expert. And, most doctors just want to practice, and they're stuck doing all this other stuff. And so we want a system that is more transparent and more accessible to you for your patients. So with that, I'll say thank you very much for your attention, and I'll take some questions. Yes, Greg.
Hey, Deborah. I wish we could clone you in 49 other states.
Thanks, Greg.
Representing Bastyr University in the state of Washington. You've just been so good to the CAM professions. Wanted to just ask about clarifying the regulatory language on non-discrimination. Will Mr. Larson, who you mentioned at the beginning, is he the one who's actually pursuing that, or who within HHS has been charged with clarifying that language?
Well, it is Mr. Larson, who's head of CCIIO. So it's the consumer. Matt, do you have a? It's CCIIO, which is in HHS. It's under the Medicare. It's under CMS. That I know. which covers Medicare and Medicaid. And it is Steve Larson. And reporting to Steve Larson is Gary Cohn, who's the former chief counsel of the California Department of Insurance, really smart, great guy, and his team, and that's the group that I talked to, and they will be doing the implementation of 2706. And as I said, they're a clean slate about it because they have so much on their plate that they haven't even begun to really think about it, which is an incredible advantage for us. So I'm going to really think about how to write rules, what should be in the rules based on my experience, and I'm going to send it along and make a suggestion. And then, of course, we've spoken to, leaders in the health and the Senate, particularly Senator Harkins, who's a very big champion of CAM providers. They are willing to assist in any way possible for a successful implementation because 2706, was Senator Harkins' amendment to the Affordable Care Act. And I also understand, I'm told this, I've never seen it, someone sent me a copy, but the attachment was empty, that the AMA does have a provision, a resolution to try to repeal it. And that's important for you to know. And by the way, in our state, the insurers try to repeal our anti-discrimination provision, I think 5 to 7 times. Every year they failed. I even went down and testified on its behalf after I left office as insurance commissioner. So I don't know what the AMA is going to try to do, but that's one potential area to look for. Nancy.
Hi, Deb. Thanks for everything. I'll give you a little peer review on your outcomes. Fabulous. You get an A.
Thank you.
I wanted to ask you, in 5101, the National Healthcare Workforce, it does say licensed CAM providers and integrative healthcare practitioners. So where in the implementation of the non-discrimination, where it says healthcare providers, are they going to be included? And they're not, with regard to your acronym, all licensed people. Even the naturopaths who aren't licensed in every state should come under, perhaps, that rubric of integrative healthcare providers. And with regard to chiropractors acting within their scope of practice, what about how is it going to be dealt with if they do nutrition or homeopathy within their within their scope of practice?
So I'm trying to think if 2706 uses the word license.
No,
I don't think so.
It doesn't.
It just uses the word
just
scope.
says healthcare providers, and it does use scope of practice. So somewhere in the dialogue, we need to include the integrative healthcare providers who IHPC did identify at the congressional briefing as state certified or national certified according to a certain accrediting agency. So they're coming on the scene. They do need to be recognized, and so I'd like to see them in that acronym somewhere.
You're right. I just thought, well, my CLIP acronym maybe is not the right one because it says the word licensed, and it doesn't say licensed in the law. But that's a question. It's a really good question, Nancy, and I have to think about it because I was asked this just a few days ago by email. What about the states where naturopathic doctors aren't licensed? How will that apply? And that's something incredibly good question we have to think about and talk about.
All right,
good.
We'll brainstorm over that.
Okay.
Thanks, Deb.
Okay, I'll hold it. Just a couple of clarifications. Thank you for all your work.
You're welcome.
I'm not as savvy with the terminology. Could you clarify the every willing provider issue? Because what I heard in passing was that could be a loophole for opposition. We don't have to provide any opportunities for access for certain groups just because they want to be part of the game. We don't have to deal with them.
Really good question. So, and I might have gone over it too fast. And there's, it's kind of a term of art. In every willing provider law, and the only place that I know of that they have one is the state of Kentucky. Maybe you know of other states. Says that every provider who comes to a state, and I assume is licensed, has to be on a panel. So Blue Cross of Kentucky, if there is such a company, has to take every single chiropractor that comes along and put them in their network. Now, it's kind of interesting because the insurers say, well, oh my God, you know, if we have every provider, it's going to cost us so much. Well, no, it's not, in the sense that, you know, their patient size doesn't change, and so therefore they're just spreading the cost across a larger network, and that's every willing provider. But it has to do with individuals. Whereas every category provider, which is ECAP, which is what we call it in Washington, or the anti-discrimination provision, is about groups of providers. So that means that there has to be chiropractic, doctors of chiropractic care in your network, or doctors of naturopathic doctors or acupuncturists. You can't exclude whole groups. So those are about groups. Now here's the key though. Well, you know, we had the experience where Group Health of Washington only allowed 3 naturopathic physicians. And so I was still commissioner. I said, excuse me, but you have, I don't know, 200, 300,000 people in your in your book of business. You cannot have 3 naturopathic physicians, and the term of art for that is network adequacy. You have to have an adequate network, and I always give the example. Look, a health plan can save money if they have no cardiologist on staff, because then you won't treat cardiac patients. Well, you have to have a cardiologist, and you have to have enough of them for your patient population, and that term is network adequacy. And I think that's going to be the key for implementation, and I think I'm going to tell HHS that that's going to be the key, network adequacy, because if a plan says, okay, we're going to have chiropractic, and they're going to have one chiropractor in all of Seattle, or one chiropractor, in Chicago, then that's going to be an inadequate network. And I know that there are network adequacy standards in the Affordable Care Act in general, but I think that's going to be the key to implementing. But once again, this is about groups and about an adequate network, but not every single one. When it's every single doctor, then it's an every willing provider law, which, much to my surprise, was upheld by the U.S. Supreme Court.
Another clarification, thank you. Another clarification, this is more legal terminology in the industry, and again, I'm not savvy. Service versus mandate. When you were talking about the Ninth Circuit's decision, I didn't quite follow what the importance of that distinction is.
Really, thanks. This is a really, really important distinction. And in fact, there's some groups internally who are arguing it now. I think in the state of Vermont, is there anybody here from Vermont? When they implemented a similar type of law, access, they defined it as a service. That's what I'm told by the doctors in Vermont. And here's the pitfall. If insurers can argue that you're adding services, then they can argue you're adding cost. And that's not how the law worked in the state of Washington. And when I say, and I think that the Ninth Circuit Court of Appeals, what's important is they said, look, every category provider, an anti-discrimination provision is not a mandate, because remember, mandates relate to services. We have in the statute in the state of Washington 43 mandates. One of them is, because I have a friend who had a child with this, I always remember it, PKU, phenylketonuria. And we also had we actually had a state senator with TMJ who couldn't get treated. And now we have a mandate for TMJ. And early on, no one, they weren't covering breast reconstruction for women with breast cancer. So those are 3 of our 43 mandates. And so in every state, you will find a legislator who has a constituent that comes to him and says, well, I've got, I've got testicular cancer and they're not covering it, or something. And so they pass a separate law, for that. By the way, the business community hates the mandates, and they're always trying to repeal the mandates because they say it adds costs. Well, if we have to cover PKU or TMJ, it's going to add cost, you know, to the whole healthcare process, and we're going to have to raise rates. That's the argument you always hear. So if they say, if you say that going to a doctor, a chiropractor is a service, it's going to add cost. But if you say, if you look at it this way, which is how we looked at it in Washington, and this is a really important distinction, if you have a back problem, you have a choice. You can go to an orthopedic surgeon to have it treated. You can go to a chiropractor to have it treated. You could go to a massage therapist to have it treated. You know, and if any one of them gives you relief, then you don't go to the other one, and therefore it's not an added cost in the healthcare system. So that's why it's really, really important. It's about providers, not about services, because then you get into that pitfall of allowing them to argue it's an increase in cost when it really is not. Nancy.
So then with regard to the mandates for the state insurance exchange, they have a mandate for the essential benefits package to include prevention and wellness. So when I spoke at the stakeholder input about that, I said, well, what about chiropractic care as a wellness service, providing wellness, which they don't cover at all now, and they didn't, or prevention, and they didn't know how to address that. They said, we're waiting for Blue Cross Blue Shield said we're waiting for a definition of prevention. From who, I asked, and they go, well, HHS, and then
They're not going to get it.
they're not going to get it. Jeff Levi from the Prevention Council, well, you know, are you informing them on a definition? They said no, but is that a mandate? You know, how do you frame it?
I think this is really important. It depends on, I think that Blue Shield is probably right, or Blue Cross is right, that they need to define, you know, what prevention is. That I know currently in a lot of insurance contracts, they specifically define what things are defined as prevention. So, I give you an example. A mammogram, which I think is prevention, is not covered as prevention. It's just covered as a service, and therefore, I know that under our Blue Cross contract in the state of Washington, you don't have to pay, your deductible does not apply to preventive services. So that's why it's important about whether or not a mammogram is a preventive service, and it isn't. So that they specifically define what preventive services are, like a checkup or something like that. And I think that's the key to trying to figure out the answer to that. And I think it's going to be important. And I know that prevention is covered under the ACA, and I know I've looked at it, I just cannot remember if it specifies what prevention is or what's covered under prevention. And I'm sorry? Yeah, so I think it did expand. Now, so look. All right. So look, obviously a chiropractor can't do a mammogram, but let's say a naturopathic doctor can. I don't know if it's in their scope of practice for them to do a mammogram. So then it's the ND that can do the mammogram, and it's covered under prevention provision. I think that's the answer. I think it depends on what the services are, whose scope of practice matches up to the services. So I think, once again, prevention is not going to be about who the doctor is, because it relates to benefits and services. Does that make sense? I know that there's a lot of confusion because benefits and services tend to kind of cross over each other. But that's how I think about it, and it's worked for us. Well, first of all, you're using I think mandate is a verb and a noun. And to mandate something is a verb. A mandate, like covering a mammogram or PKU, that's a noun. And so if they mandated coverage of prevention services, that's just the verb. I don't think it means that it's a mandate, the noun. Does that make sense?
No.
John, I know you're going to clarify me.
No. I'm asking the same questions to get clear on. It's challenging. I had a different question, so if you're...
No, I think so. Does that make sense? I think it is a noun and a verb.
It is.
Okay.
That much I know. My question is I mean, who else is on the ground? Who are you finding as you're sniffing out around this? Is anybody else playing?
Good question.
And from whichever angle, I'm curious.
Very good question. There's nobody out there, as far as I know, which I think is a clean slate. But I have said I do work professionally with the naturopathic profession, and actually my co-lobbyist is Rick Miller, I know, who works with the Chiropractic Association in DC. He's a great guy. I've really enjoyed working with Rick. And, you know, we're out there, and it's very quiet. I don't want to raise the AMA's attention at all, but I do think it's really important to begin to create coalitions with healthcare groups, because I think this is going to be really important to show that the public cares about this. I actually have a relationship, for example, with Healthcare for America Now, which is a very big healthcare group in DC, and so I'm looking for some coalition building, and I think that's one thing that you should be talking to your associations about, because it's one thing for an ex-insurance commissioner to go in and talk to them. It's another thing for doctors and patients to go talk to them, and they want to see doctors and patients, not just experts. But coalition building, I think, is the absolute key to this. And let me just say one thing. When in our state they passed health care reform in 1993, in fact, I got to go to the Clinton White House about 5 times because they were constantly picking our brains about the passage of health care reform. And then in 1994, our legislature flipped. We were very Democratic. It went to Republican when Newt was elected Speaker, and they had the Contract for America. And some of us called it the Contract on America, but I won't be partisan. The Contract for America, and they repealed most of our health care bill. They did not repeal every category provider. I always tell people it was because of my political brilliance, but the truth is they overlooked it. And so we implemented it, and it remained popular. And so no matter what happens to the ACA, and whatever the Supreme Court decides to do to it, this is a really popular issue that lives beyond any healthcare law. And one of the things that I know that the professions are trying to do is that there are opportunities for CAM providers all over the federal government, in Medicare, Medicaid, and that's a coalition building goal. Anyway, John, you had another question.
I think we're in time. Well, I think that's the importance of. My question actually is whether or not this is going to be rolling out ultimately as a state-by-state issue. I mean, we're working federally, but it sounds like with the way that the definition of the benefits has gone to state, are we going to end up basically with a whole series of legal issues and battles in each state being fought out over this, do you expect?
I think that's an incredibly good question, because it looks like they kicked the essential benefits package down to the states. The exchanges are on the state level. And so, and I think that it takes the heat off of HHS and the White House to have the states implement. And so I think that's a very, very big, important issue. I have a letter that was written by 8 members of Congress to Secretary Sebelius, shall I say, not extraordinarily happy with the fact that they delegated the essential benefits level to the state level. So I think that this, the proponents of healthcare, want the federal government to define as much as possible, and I think that's what we would like to see happen. But I think that the pressure to send it down to the state level is immense, and so I think that's something that we have to look for and be prepared for, and argue against if possible. It won't take a lot to define the implementation of this law and then say, okay, states, this is how it's supposed to work. And I think that should be our goal. But that's a really, really good point, John. So, thank you very much.